All right. You guys have any questions from last time? Anything about the epilepsy section we talked about? All right, fantastic. So we're going to cover the second part of neurology. First thing we'll talk about today is Parkinson's disease. Have you guys covered that previously? Okay. Next class. Okay, so you'll at least get some information on the pharmacotherapy of it. We'll give you some basics about it. Does anyone know what Parkinson's is? Could someone describe it? That's more like multiple sclerosis. This is a different disease pathway. It's a brain issue, yeah, for sure. Yes, dopamine's a big one, right? So this is one of those things where we're having this kind of progressive loss of these dopaminergic neurons. And I'll kind of show you the pathway here that we're really concerned about. But basically, dopamine is very, very important, especially amongst the nigrostriatum, in order to help initiate movement. And so when you have loss of these neurons, you end up having a very hard time actually initiating movement for some of these patients. It's kind of why you get these kind of 4 cardinal signs that they talk about. So one of the things they have is this tremor at rest, which we'll talk about as more of an acetylcholine problem. And this is important because when we talk about the medications we're going to use, they're going to be directly affecting these neurotransmitters. But they're going to have these kind of resting tremors. They're going to have a very hard time kind of initiating movements, and so this is why they have kind of this shuffling gait that happens in kind of more progressive disease. Obviously, it's on a continuum, so very early onset or very early stage of the disease, it won't be as pronounced, but this is kind of more of a progressive type patient where you'd see that. So they also have this rigidity because, again, it's difficult to initiate movements. Hypokinesia, anyone have an idea what that means? Yeah, basically decreased movement. So again, it goes back to not being able to really get that movement initiated. I don't know why my screen went off. So the other thing though is they'll have like some postural instability. So that, and again, goes back to their movement issues. So I'm going to the next slide. As far as etiology goes, there's lots of different ones that will affect this. You'll find that progressive age is usually one of the big things, one of the big features. Obviously, some people have some genetic predispositions to it. Interestingly enough, even though smoking causes almost every other disease state, there's actually some evidence that smoking actually is protective against Parkinson's. Why that is, I have no idea, but it's kind of interesting. But we can have some secondary drug causes for this. And so when we talk about in the behavioral section, we talk about antipsychotics, a lot of those drugs are blocking dopamine. And so if you block dopamine, you'll have symptoms that look very much like Parkinson's, kind of like a drug-induced Parkinson's kind of reaction. So we'll talk about those later. But certain other chemicals like carbon monoxide, methanol, all of those can cause damage to the brain, causing the cells, those dopaminergic cells, in order to be progressively lost, and then you have loss of that transmission. Okay. So going to the next slide. Okay, so anyway, so looking at the pathophys, so we have the substantia nigra that is going to be having these dopaminergic projections. We're really concerned about these red ones right here, right? Hey, you're back. It turned back on, so.
Yeah. I'm going to let her know because she found someone.
Okay, we're going over the base. You can catch up. It'll be fine. Anywho. Basic thing though is we have 2 primary dopaminergic type of neurons. We have these stimulatory D1 and these inhibitory D2. Both of them end up getting depleted. Both of them have their role in causing this kind of progressive difficulty in initiating movements. I'm not going to get like super in depth on like the neuronal circuits that happen with that. You might cover them in other classes, but just know that as you lose these dopaminergic neurons, initiating movements become much more difficult. They're just a whole lot more of a kind of inhibitory kind of influence on the thalamus, and that really helps to prevent those movements from occurring in the first place. So anyway, the other big thing, this is a good point for you to come back into, because this is important. The other thing, as you lose dopamine, there's kind of this seesaw sort of pattern with dopamine and acetylcholine. As you lose dopamine, you get more acetylcholine being released in the brain. That's important because when you think about skeletal muscle activation, what neurotransmitter is really important for activating those muscles? Acetylcholine, right? So if you have more acetylcholine, right, that's why you get that resting tremor, because they're having too much acetylcholine activity, and that's what's causing that skeletal muscle activation, right? So again, even though they have a difficult time initiating movement, they still have that resting tremor. Has anyone seen that movie Awakenings with, I think it's like Al Pacino and Robin Williams? Check that movie out. It's actually a really good kind of portrayal of early treatment of Parkinson's disease back when we didn't even know what the heck the problem with the disease was, and how an early treatment actually was able to really reverse a lot of these things. But again, you'll see kind of how this treatment only worked for so long for these patients, as we'll see as we move forward. But anyway, again, acetylcholine is really important for the tremor aspect of that. So looking at dopamine metabolism, the key takeaway points from this is that when you have these dopaminergic neurons that are producing dopamine, you're starting off with a precursor like phenylalanine or L-tyrosine it gets converted into. These are things that are taken in from our diet, or that our body's producing these amino acids, and we're getting it up into the CNS. Again, crossing that blood-brain barrier is going to be a bit of a problem for some drugs, as we'll see in talking about this a little bit later on. Anyway, when you get this conversion over to L-Dopa, this is what we're this precursor to dopamine. There are two main enzymes we're going to be looking at as far as drug interactions go, and so we're looking at COMT. This stands for catecholamine O-methyltransferase. That is responsible for metabolizing dopamine, and there's another one called monoamine oxidase. There's a couple of different versions of monoamine oxidase. This will be important when we talk about depression a little bit later on. A lot of old school antidepressants affected monoamine oxidase. There's an A version and a B version. We're really more concerned with the B version, and this is going to be more specific for dealing with Parkinson's. Anyway, both of those work to metabolize dopamine, and we'll see that if you were to inhibit the metabolism of that dopamine, you'd have higher levels, and then hopefully you'd have better movement. So that's going to be one of the treatment modalities we'll look at a little bit later on. Dopamine can then be released from these vesicles and interact with those neurons. It leads to eventual movement. Just know that there's going to be some dopamine transporters. We're not going to worry about those quite so much, but these help to recycle dopamine as well. So again, looking at those kind of four cardinal signs of Parkinson's, you're going to have this hypobradykinesia, so very difficult to make and initiate movements, that resting tremor, some rigidity, and that postural instability. There are other things that come about this as well, especially as they get more and more progressive. So you can see a lot of motor symptoms. Again, you can have things like dysphagia. They can have a difficulty swallowing at some point. So again, this is a lot of the reasons when they can't really perform their daily activities of daily living. This is when they usually need some sort of institutionalization or some sort of home health care, something like that. But they have a very difficult time initiating these movements. And when they do initiate them, they're usually less pronounced than they would be if they had normal dopaminergic transmission. See things like incontinence, constipation, so it kind of goes both directions there. Orthostasis, so they can have issues with their blood pressure, which again, having drops in their blood pressure also could lead them to having falls. It goes along with their postural instability. A lot of mental status changes that can occur here as well. So like Parkinson's-related dementia can be a big cause for mood changes and alterations in mental status. And then it can have some other kind of miscellaneous signs and symptoms. So anyway, so we're going to be looking at trying to reestablish this normal dopamine transmission, and that will help to fix a lot of these problems these patients are having, at least on a temporary basis. Because unfortunately, what you're going to find is that at the end of the day, once you deplete all the dopaminergic neurons, there's really not a whole lot you can do for those patients. And so again, we're just trying to stave off the inevitable and try to help improve the symptoms for these patients. So as I mentioned, we want to minimize reverse functional disability, and then we want to prevent some of those long-term complications. So obviously, non-pharmacologic therapy is very important here. So education is really good. Trying to help them with speech and exercise therapy can help to maintain some of their motor function for longer. There's some surgical interventions you can do. I'm not going to really talk about those too much, but we'll talk about the pharmacological therapy here. And the big thing to know is there's going to be early treatment, which is hopefully going to help with symptoms and also help to hopefully prevent progression of disease. And there's going to be more late complicated Parkinson's disease. And we'll see how the therapy changes based on kind of where they're at in the disease process. So early uncomplicated Parkinson's disease, we'll look at drugs that can help with neuroprotection, meaning they help to prevent further degradation of the dopaminergic neurons. So we'll have monoamine oxidase B inhibitors, and we'll also have dopamine agonists. This will actually take the place of the normal dopamine that your brain would be releasing into those synapses anyway, right? So it's kind of as a replacement. If we can kind of supplement that, then hopefully the brain's not having to make as much of its own. Hopefully we'll save those neurons a little bit longer. And then as far as symptoms go, we'll see some symptomatic care occurring here with anticholinergics. This is really going to be important for helping with the tremor. You're going to have the monoamine oxidase B inhibitors will also help by increasing low levels. We'll look at those COMT inhibitors. So again, both of these work similarly by blocking different enzymes to increase dopamine levels. And then we'll have some dopamine agonists. We'll look at two different varieties there. And then we'll actually have some dopamine precursors. This is going to be the gold standard of therapy. If we can give a precursor that your brain then turns into dopamine, that's going to be very useful for helping to alleviate those symptoms. So we'll look at those in just a little bit later. So one of the reasons why we think that if we can spare the brain from having to make its own dopamine, we can try to stave off some progression of disease is because of this idea of this kind of excitotoxicity, this kind of development of free radicals that can damage the neurons. So if you imagine here, and again, I'm not going to have you memorize this by any means, but when you have dopamine being metabolized by something like monoamine oxidase B, you end up getting some a metabolite, but you also end up getting H2O2. Anyone know another name for that? Yeah, hydrogen peroxide. So once that peroxide breaks up into its kind of freely acting free radicals, notice here you have this being developed here, that can go along and damage those neurons, right? So we've seen free radical damage being done before, looking at chemotherapy drugs and things like that. but that damages the neuron. So if I can inhibit this enzyme, prevent that dopamine from being broken down, then hopefully I'll ultimately end up decreasing the amount of that free radical being formed. And so that can hopefully save the neuron for a little bit longer. Again, this is not going to be a permanent fix. You're not going to reverse any disease, but hopefully it helps slow it down a little bit. So we have a couple drugs that work as a monoamine oxidase B inhibitor. So this will be including selegiline and then rasagiline. You'll find that the selegiline is kind of interesting because even though it's inhibiting monoamine oxidase B, it actually has kind of an amphetamine-like structure. So this is one of those things where if you were to drug test someone who's on selegiline, you'd actually find they would test positive for methamphetamine, right? Which is kind of interesting, but it's one of those things where it's like, no, your grandpa's probably not doing meth. He's probably just taking his drug for Parkinson's, right? So it's one of those things to consider there. And then as far as side effects you're going to see, you see a lot of these dopamine-acting drugs kind of have similar side effects, but you're going to see some insomnia, possibly hallucinations that can happen. And again, some of the stuff you don't notice if it's the disease process or the medications. So you really have to kind of make sure you kind of know what their baseline is, kind of know how things are changing as they go along. But orthostatic hypotension can be another big one. And again, falls is really important because if they fall, they break a hip, that has very, very significant morbidity and mortality implications there. Rasagiline, again, works very similar to selegiline. Some fewer side effects, so some people may like that a little bit better. It just depends on how the patient responds to it. And we also will talk about serotonin syndrome. Anyone ever heard of that before? A serotonin syndrome. So we'll talk more about that when we get to the behavioral section. Basically, it is a complication of using medications that increase levels of serotonin. I'm not going to get too much into detail here, but just know that these drugs that work on blocking metabolism of these catecholamines. So again, monoamine oxidase B is not just specific for dopamine. It can affect other things like serotonin to some degree, things like norepinephrine. When you inhibit breakdown of those catecholamines, you can see kind of excess activity of them, and you can lead to some issues there. So really kind of this hyperadrenergic kind of state. But we'll talk more about that in the behavioral section later on. But you can use these as monotherapy early on in Parkinson's. It will help to hopefully stave off some of that progression disease for a period of time. And the contraindications are really important here because this goes back to that serotonin syndrome risk where you have other drugs that can increase levels of serotonin. You mix it with this, there's a risk that they can have some side effects from that. We'll talk more about opioids a little bit later on in the class, but these are some opioids you may see being used for pain management. Which can increase levels of serotonin. Obviously, some pathomimetics, things like ephedra or amphetamines can do this as well. And then mixing with other monoamine oxidase inhibitors. This is just some examples. I'm not going to ask you very specifically like which one not to give it with, but if I were to say, the patient was started on a drug that increased serotonin levels, which one of these Parkinson's disease medications would you maybe not want to administer along with it? You'd want to focus in on the monoamine oxidase B inhibitor, right, based on that metabolism property. And even some anesthetics could lead to some complications here. So there's also some dietary restrictions. So there is a component of some of these foods called tyramine that is a precursor for a lot of catecholamines like norepinephrine, epinephrine, dopamine, all these things. And so if you have foods that are high in tyramine content and you're blocking the breakdown of some of these catecholamines, this is where I can see some of these side effects. And you see things like increased blood pressure, increased heart rate, you can see changes in mental status, sweating, all these different things. And so it's important to know what foods are high in tyramine. So some good examples, and again, these are usually kind of all the best foods in life, unfortunately. But you have things like aged meats and cheeses will have a lot of tyramine in them. You'll have things like fava beans, you'll have red wine, pasteurized beer, a lot of sausages and things like that can all potentially have a lot of tyramine in them. And so when you have someone who's on a monoamine oxidase B inhibitor and you add that food on board, again, you can have kind of an excess of these catecholamines being formed and preventing that breakdown. That's where you can see these symptoms come up. This will be more important when we talk about the monoamine oxidase inhibitors and talking about the drugs that we use for depression, because those are non-specific and they work on the A and the B version. So just know this is kind of a theoretical concern again, but it's important to educate them what foods they should be kind of avoiding. Okay. So looking at the drugs we can use for symptomatic control, we have the anticholinergics. Again, these are blocking the acetylcholine substantia nigra, and this is going to help us with that tremor, basically. Obviously, some of the issues here with anticholinergics, you can see some cognitive impairment, just like we talked about with our non-specific H1 blockers. Remember, we have those kind of first-generation H1 blockers like diphenhydramine. Those cause anticholinergic symptoms too, and that can lead to things like altered mental status in elderly patients, and etc. But you also have these other adverse effects. So you remember the mnemonic we use for those first-generation antihistamines, that anticholinergic effects? what was it? Dry as a bone, hot as Hades, blind as a bat. Yeah, so remember those symptoms because these will come up again here for these patients as well. Because again, we need to have something that's going to be able to cross that blood-brain barrier. We don't want to have something like a cetirizine because that's only going to doesn't really have good anticholinergic properties, never crosses the blood-brain barrier. So we can see we'll have drugs like diphenhydramine can be used here. And we also have a few other ones that are going to be more specifically blocking acetylcholine, not really antihistamines, but you have things like benstropine and trihexyphenidyl. Those are two of the big ones. You'll see this come up again when we talk about some antipsychotics. These are actually good reversal agents for some of the side effects for antipsychotics that block dopamine. So again, remember that seesaw effect where if you have less dopamine activity, you're going to have more acetylcholine. Now we're trying to give a drug that's blocking acetylcholine to try to get things back in order a little bit. Okay, so those are the big things to remember. Remember those side effects associated with anticholinergics. Another one we can use is called Amantadine or Symmetrelº. This one kind of has an unclear mechanism of action. Some people think it has some anticholinergic activity, but it also has works as an NMDA antagonist. Anyone remember where we saw NMDA last week? It's a type of glutamate receptor we talked about. Again, I'm not going to get super specific on the receptor subtypes of glutamate, but just know this is blocking one of those glutamate receptors, and this is thought to have some effect here with these Parkinson's patients. Again, usually used as early on as monotherapy, is not really going to prevent progression of disease like you would see with the monoamine oxidase B inhibitors, but may help with some of the natural symptoms that they're experiencing. Big things to note though is that tolerance to a lot of these medications develops over time. Some of that is due to disease progression, some of it is just due to normal homeostasis developing against some of these drugs. So just be aware that a lot of these drugs will lose effectiveness over time. You may either need to change your dose or switch over to a different medication, right? Okay, we also have some dopamine agonists. So these are very specifically just going to replace the dopamine that our patient would have been producing otherwise. We'll talk about a few different varieties. We're going to have our ergot derivatives and our non-ergot derivatives. I'll kind of delineate between those two in a little bit. We'll also talk about ergot derivatives a little bit later when we talk about migraines as well. Basically, you can use these as first-line therapy, and you'll find that they're not really as effective as a drug called Carbidopa Levodopa. Anyone ever heard of that drug before? Called Sinemet. That's our gold standard drug. We'll talk about it a little bit later. So when I say something that is a precursor to dopamine, this is the drug I'm talking about, but we'll talk about that a little bit later on. Again, usually not as effective, but ideally for these Parkinson's patients, if you can hold off from giving them Carbidopa, Levodopa as long as possible, that's going to be better for them because that will leave this drug to be effective for longer. So again, we're trying to use other drugs first, and whenever those start to fail, then you switch over to this Sinemet that we'll have here. I'll talk about that a little bit later. So just be aware, though, that if you're adding it on to someone who's already taking this drug, levodopa, because it gets turned into dopamine, you need to drop the dose a little bit because otherwise you have too much dopamine activity. You can have what we call dyskinesias, which I'll talk about a little bit later on as being a problem of too much activity there. Because again, if you imagine if I have too little dopamine, I have a hard time initiating movements, but if I have too much dopamine, what do you think would happen? Too much movement, right? So you can end up seeing dyskinesia, have them get very, very rigid in some cases. You have muscle breakdown, things like that. So we'll talk about those a little bit later on. So anyway, again, you see a lot of orthostatic hypotension associated with these dopaminergic acting drugs, a lot of nausea and vomiting along with that. And again, some of this stuff is hard to tell. Is it just going to be due to the disease progression, or is it the medication? So you got to look at the before and after. This is where other family members can be very helpful with this because a lot of times patients may not be kind of aware of these changes and may not really see them themselves. So we'll talk about the ergot derivatives in just a second here. So anyone know what this is? This wheat here, and this is actually a fungus. So actually the ergotamine is actually derived from a fungus. Anyone ever heard of St. Anthony's fire? You know what that is? It's kind of interesting. So there's it's kind of this older story where these, back in like the Dark Ages, and you'd have these villagers and peasants and things like that, and they would make bread from this rye that actually got contaminated with this fungus. One of the things you'll see with these dopamine agonists, these ergot derivatives, they actually cause very significant vasoconstriction, right? Especially in the periphery. So like the fingers and the toes, they would get so vasoconstricted, they would feel like they were on fire. They'd have these paresthesias. They would eventually get gangrenous and have to be amputated potentially. And so they call that St. Anthony's fire because the way they fixed it is they went on these religious pilgrimages to St. Anthony's Cathedral, which is somewhere nearby, and they noticed that as they got to the cathedral and they prayed there, they got better. What actually was happening, though, they were actually getting away from the contaminated wheat, and they were not eating that bread anymore that had that fungus on it, and thus they were getting better, right? So it's a matter of continuing to be contaminated with that stuff. So anyway, so we actually got our ergots from this fungus, and actually the drug LSD also is derived from this fungus as well. So also another little fun fact. Anyway, the main ergot derivative we have for Parkinson's is called bromocriptine. Again, just working as dopamine would by activating those receptors. We also have a few non-ergot derivatives. This is going to include pramipexole, ropinirole, and rotigotine. Some of these drugs you'll also see being used for restless leg syndrome. I'm not going to get into that too much here, but you may see them used there occasionally. Again, the nice thing about transdermal product, we think, is the benefit of that. Get help with compliance, right? So if I don't have to give it quite as often, I can have a caregiver who can apply that. Just make sure they rotate the site, because if you keep applying at the same site, you can see some irritation that develops, skin breakdown, and things like that. So you want to be careful of that. Okay, so really the gold standard treatment for Parkinson's is going to be Levodopa, Carbidopa, or Sinemet is the brand name here. And so Levodopa itself is actually the precursor to dopamine. It gets that L-Dopa. If you go back to that slide with that neuron with the enzymatic pathway, you'll see that L-Dopa is one of those precursors, and that gets turned into dopamine. This is able to cross the blood-brain barrier, which is great, because if I were to actually give dopamine itself, the patient would not be able to get any benefit from that, because it doesn't, it would either get digested by the GI tract or not cross the blood-brain barrier, so that would not be any good. And so again, you have a little bit of it that gets converted to dopamine in the peripheral, but that causes a lot of side effects as well. So we don't really like that. We don't like to see those arrhythmias and orthostatic hypotension. So this is why we add on the Carbidopa. This is actually going to be an inhibitor of this enzyme, this L-amino acid decarboxylase. This actually prevents levodopa from being converted to dopamine in the periphery and allows it to be able to cross into the blood-brain barrier, get to those neurons, and then get converted to dopamine there. This helps to limit a lot of the side effects, but this one actually has no actual activity itself. Really, the levodopa is the business end of the molecule. This just helps to get it where it's going. Does that make sense? Okay. This is a combo drug. Yeah, you would only ever give these two in combination together.
Are they two separate?
No, it comes as a combo product. Yeah, so that's why I always talk about them together, because they don't really ever come separate. Yeah, but Sinemet is the brand name. I'll probably just refer to as that, because saying Carbidopa, Levodopa over and over again is going to drive me crazy. So Sinemet is the gold standard here. So you're going to find that levodopa, carbidopa, or Sinemet, again, it resembles a lot of amino acids that you would normally be taking into your diet anyway. So there's some competition there. There's only so many amino acid transporters in the GI tract. So one of the things you can find is there's actually pretty variable absorption here. So one of the things that we'll actually tell patients if the Sinemet's not working very well for them is to see where they're timing it at. So if they're consuming it at the same time as they're eating their lunch and they're having a big turkey sandwich, that turkey is going to be fighting for the same transporter. So if you can separate it out, that can actually help with that. That's one of the big patient education points you can say. You have it on an empty stomach, that will allow it to be absorbed a little bit better. So that can be very useful there. And just keep in mind that when we have, normally the levodopa itself has a pretty short half-life, but we can combine it with things like carbidopa. That helps to extend the half-life, helps it to work a little bit better. And notice here when we add another drug, we'll talk about this COMT inhibitor and tacopone a little bit later on. This can be a very useful drug to add along with it, because again, that will help to prevent it from being broken down, help it to stick around for longer. So we'll talk about that combination a little bit later on. So you can use this initially for Parkinson's disease, but the concern is if you're having this convert over to dopamine in those neurons, you're producing more of those free radicals, hopefully, or you're causing damage done to those neurons. So the idea is that, maybe if you can hold off on this for longer, then you can hopefully, it'll remain effective for longer. Because eventually, this stuff's not going to work, because if all those neurons get wiped out, guess what? None of that levodopa gets converted into dopamine, and it's not going to really be effective. Okay, so that's really the concern there. But all Parkinson's patients eventually, on a long enough timeline, will require use of Sinemet at some point. Again, the side effects are very, very similar, because again, they all go back to that dopamine activity. We'll have some of that nausea, vomiting, changes in mood, orthostatic hypotension. So again, very similar side effect profile for all these drugs. So again, I'm not going to have you memorize the dosing, but just note here that a lot of this is sometimes based on the carbidopa dose. So if you ever see that, make sure you're looking into your dosing guidelines to see, okay, is it dosing based on the carbidopa component? And then when you're dosing that, make sure that makes sense based on what you're looking at. Kind of similar like when you're looking at a penicillin mixed with a beta-lactamase inhibitor, you don't dose it based on the beta-lactamase inhibitor, you dose it based on the penicillin component. But if you're looking at the wrong part of that drug, you can dose it incorrectly. So I've actually seen that happen before. So again, just be aware of what you're actually dosing it on. Same thing happens with Bactrim. You guys remember that, sulfamethoxyl trimethoprim? You always dose it based on the trimethoprim component. So just be aware of that. And then also we can have something like an oral disintegrating tablet, so an ODT. Why would that be beneficial for these patients? Yeah, so they have dysphagia and they can't really swallow that well. This could be very useful for them. So in some cases, in some patients, you may even have actual administration of this stuff via duodenal pumps. They actually may have like an ND tube, I guess, or something like that. It would actually just instill directly there to help that administration. So it just depends on how progressive the patient is. But usually tablets are the best way to go. Sometimes they'll have liquid formulations or like an ODT. So again, I mentioned how we kind of want to hold off on this as long as we can. Dyskinesias are going to be very common with levodopa, and so I'll show you some graphs here in a little bit later. But again, when you have too much dopamine activity, you have what we call dyskinesias that can occur. We have kind of inappropriate movements that are happening due to too much dopamine activity. So I'll show you that later. But we do know that levodopa reduces mortality in PD, so that's kind of the other kind of flip side of that, where it's like, well, maybe you should use it. But the reason why we typically will say, well, let's use dopamine agonists, let's use monoamine oxidase B inhibitors first, because hopefully that will help to save those neurons as long as you can, and then when those are ineffective, switch over to levodopa. And then one of the last set of drugs we have is called the COMT inhibitors. These are just blocking that enzyme catecholamine O-methyltransferase. These don't have the same kind of neuroprotective effects as the monoamine oxidase B inhibitors do, but sometimes you'll actually add these drugs on to levodopa, carbidopa in order to help to extend the half-life a little bit. So the primary one we're going to use is called entacapone. I think I have that a little bit later on. But just note, think about the dose of levodopa you're giving. If it's going to have a longer half-life, I don't have to give as much drug. And so this can be an important thing here, because if you don't reduce that dose, you may see more side effects associated with that. So watch out for that. You do not want to use these in combination with a monoamine oxidase A inhibitor. Those are going to be the antidepressants we'll talk about when we get to the behavioral section. Just know that by mixing those two, you can end up having more risk for that serotonin syndrome we talked about previously. And this one, these can cause a brown-orangish discoloration of the urine. Again, always let patients know if you ever change color of the pee or their poop. So tolcapone we don't really use anymore due to hepatotoxicity. It's kind of a black box warning, but entacapone is the one I would remember for these discussions here. Again, usually given in combination with carbidopa, levodopa, usually going to be given as a combination product. We actually have all three of them put into one product there. That can be very useful, help with compliance, because again, the fewer the pills patients having to take, the better it's going to be for them. So here's a little flow chart that can kind of help you decide kind of how you're going to be treating these patients. So again, if you're starting off with your diagnosis of Parkinson's, how do you make a definitive diagnosis? Anyone know? There's like a lab test you can order. Can't really do that, all based on symptomatology. Sometimes what we'll actually do is we will have a patient who we suspect has Parkinson's. We will give them a dopamine agonist, and if they improve, then that would tell us that, yeah, there's probably some degeneration happening here, and that would be a good enough diagnosis. So there's a drug I'll talk about later called apomorphine. That is something we'll use sometimes as a diagnostic drug. Similar to if we're trying to identify someone with asthma, we'll give them a drug called methacholine that actually causes bronchoconstriction. Same kind of principle there. So we're seeing if the drug works or not. If it does, then yeah, you probably have Parkinson's. So anyway, so you're trying to identify what symptoms they're having. If they're having no significant impairment initially, you want to try to save those neurons as long as you can. So this is where adding on something like rasagiline or selegiline would be a good option here, that monoamine oxidase B inhibitor. Now, if they're only really having tremor in the less than 65, this is where you consider using an anticholinergic. The reason why we don't like to use it quite as much for older patients is due to that anticholinergic effects. They're more likely to have side effects, more likely to have mental status changes. We don't really like it as well in those patients. So, if we have a younger patient with Parkinson's, you can give something like a trihexyphenidyl or a cogentin, something like that. Can be very useful for them, just for the tremor though, right? That's only really that symptom you're treating there. If they really don't have any of that tremor, then that's where you consider something like, dopamine agonists, or going over to trying something like Sinemet, right? Because again, if they're not having the tremor, they're not really having a acetylcholine problem, giving them anticholinergic is not going to help. It's only going to cause side effects. And basically, you're just going to, we'll talk about the treatment algorithm as it progresses, but this is kind of where you start off with most patients. And obviously, they're going to continue on with like physical therapy and things like that, speech therapy, to help try to retain as much function as they can. So typically what you're going to see is that early on you're going to start with monotherapy, again trying to use things that are neuroprotective and try to save those neurons as long as you can. Then eventually they're going to require polytherapy, usually Sinemet in addition to things like tolcapone or entacapone, in addition to monoamine oxidase B inhibitor, things like that. You're going to use multiple drugs, and then eventually as everything else kind of wears off and is not really effective anymore, they're eventually going to end up just on Sinemet by itself, and we're going to see how we can try to optimize that dosing a little bit here based on their symptomatology. We try to call this a levodopa honeymoon. Basically, this is where you try to hold off on using it as long as you can, because again, once they go on Sinemet, chances are they're probably not going to come off of it. So again, if you can hold off as long as you can, that's going to be better for your patient, typically. Okay. So there's lots of complications here when you have late stage Parkinson's disease. You have these motor fluctuations that can occur, things like wearing off, where basically the drug becomes ineffective too early on before the next dose, and they start to have kind of worsening symptoms here. You can have delayed onset, where the drug is not working as soon as you would like it to, and so we'll talk about some ways we can combat that. And then you can have things like unpredictable on-off, so you're not really sure when it's going to be wearing on and off based on how progressive the patient is. And you can even have this freezing that occurs. And so if you watch that movie Awakenings, you find a lot of those Parkinson's patients before there's therapy, they're basically catatonic. They basically could not move, could not really do anything for themselves, and that is due to that dopamine degradation. Those neurons are just not there. That can be very, very problematic for your patients. We want to avoid this whenever we can. We'll talk about ways we can do that. The other thing we're talking about is dyskinesias. This is where you have too much dopamine activity. This is where you can see inappropriate muscle movements. You can have what we call punding, which is kind of an interesting thing. If you Google it, there's a cool case report that shows up pretty early on in the search, where they punding is basically where you have this fascination with like putting things in order, or like taking things apart and putting them back together. And so there's one article I found that had like these ladies that would at late stage Parkinson's disease, and they would one of them would have to line up their jewelry like just compulsively. One of them would take apart watches and put them back together. I can't remember what the third person did, but it was very the stereotypical kind of categorization, ordering, taking things apart, putting them back together that goes along with that dopamine activity. And so based on that, by kind of optimizing their medication regimen, they can get rid of some of those symptoms. So we'll talk about dyskinesias a little bit later on. And then some of these refractory symptoms, we'll talk about ways we can get around that. This is where you need to consider things like surgery, physical therapy to try to help to prevent these. Because again, when they are not able to really speak anymore, if they can't really consume their nutrients appropriately due to these changes, that's where it becomes more important to get things like institutionalization or home health care, things like that to help them out. Okay. So typically what you see when you're having a patient with Parkinson's is you have, say, initially their dopamine activity is pretty low, and you have this response threshold. This is when you get levels of levodopa above this. This is when you start to see improvement of their symptoms, right? So they're kind of hypokinesia. This is where it gets much better, right? There's kind of a high threshold here for dyskinesia, where if you get above this level, this is where you start to see some of those side effects. So if you ever look up dyskinesias on Google, you can find some good pictures of people who are having that. Usually it's like they kind of have too much movements going on. They get really kind of bound up. They may have like tongue movements and things like that happen along with that. As you find that early on, it's very hard to get the dyskinesia threshold, but as you get later and later, you're going to find this window kind of narrows into where giving even the same dose of levodopa may cause, and you have these peak dyskinesia effects that can happen here. So you can try to avoid that, and we'll talk about different means to do that. The other factor here as well is that you're going to find that the drugs, when you give them, are going to be useful for shorter and shorter periods of time as they get more and more progressive. And so when I mentioned that movie, again, I'm not spoiling anything, because again, Parkinson's disease is just how it works, but you found those patients who had basically no dopamine activity, they're near catatonic, they gave them the medication, all of a sudden they could like walk around, they could talk again, they kind of awoke them from this state, and then eventually the drug wears off and it's not working anymore, and they kind of go back to that original catatonic state. It's kind of a sad movie, but kind of goes to show you just how that disease progresses and how the drugs become less effective over time, because again, you're still having that progressive degeneration of the neurons. You're not fixing that baseline problem at all. So some ways we can do, if we're having, say, wearing off of the drug, if it's wearing off too early, we can do things like add on entacapone, right? We can inhibit that COMT enzyme, hopefully lead the drug to work for a little bit longer. We can do things like add a dopamine agonist, can be very useful here. And then sometimes what we'll actually do is use Sinemet at lower doses, but give it more frequently throughout the day. So again, be very difficult for compliance sakes, but if you do it 6 to 8 times a day, that will help to keep those levels a little bit more steady throughout the day instead of having these big peaks and valleys that happen there. Some other things you can do, add on a monoamine oxidase B inhibitor. You can try using controlled release formations. And then, again, I mentioned that duodenal levodopa infusions occasionally. There's also another drug called apomorphine, which is a dopamine agonist. I'm not going to talk about that too much here, but just know there's lots of options you can do it, and you need to monkey around with the kinetics to make sure that they're getting good, steady levels, not too high to get the dyskinesias, but it's going to stay effective for longer periods of time. Kind of make sense? So if they're having off dystonia, so again, when they're waking up and they're having significant symptoms, you can do things like adding a bedtime dose of Sinemet. You can add on, again, a dopamine agonist, something like reticulatine. Sometimes just taking their Sinemet right when they wake up can help to prevent some of these symptoms. And then even we call botulinum toxin. We talked about that briefly. What do we normally use Botox for? Yeah, you use it for cosmetic purposes for wrinkles, but you can also use it for patients who are having this spasticity, because we mentioned you have that muscular rigidity that happens here. So botulinum toxin can be used. You can inject it into some of those more problematic muscles to help kind of loosen them up and prevent that from occurring. So that's another way we might see that being used here. We'll also talk about that briefly when we get to talking about migraines later on. Again, very similar thing here. If you have unpredictable on-off, this is where I just want to point out that protein redistribution can be very useful. So you maybe avoid a lot of protein in one meal. That way they can take their medication around that time and avoid that kind of that competition there for those transporters. Let's see. Again, when you're having issues with delayed on, always look for things like drug interactions. Make sure there's nothing that's going to be either causing increased metabolism of levodopa, things like that. I mentioned that reducing the protein in the diet can be very useful here. One of the things you want to watch out for is because, again, if you're blocking acetylcholine, by discontinuing that, you can hopefully actually lead to the drug to work a little bit better. Main thing is due to the anticholinergic kind of slowing down the GI peristalsis. So if you can kind of get rid of that effect, you can hopefully have a little bit quicker absorption. That may be useful for some patients. Again, you're trying multiple things to see kind of what's going to work for them. Every patient's going to be a little bit different, though. If you're having those peak on effects, you're having those dyskinesias that happen there, again, consider lowering the dose of Sinemet. That can be useful. The peaks are getting too high. Or if you can discontinue things like a COMT inhibitor or monoamine oxidase B inhibitor, right? So again, just kind of think about things like they're having, what's the problem they're having? And they're having too much of a dopamine effect. Well, how can we reduce that? How can we, should we lower the dose? Should we get rid of an inhibitor of an enzyme? Things like that. So it kind of makes common sense if you know the mechanisms there. Just kind of showing you again, if you're dosing, typical, say 3 times a day, you can see here how they get pretty high peaks and valleys there. But doing things like having more frequent administration can help to eliminate some of that. So, for instance, if you were to, it's gonna freeze up on me. And if you were to dose it more frequently throughout the day at lower doses, you can hopefully get a little bit more of kind of a steady level instead of having such big peaks and valleys there. That's what I was trying to get at. But this thing does not want to cooperate today. It's freezing up on my end, so I apologize. It only ever happens for you guys. I don't know why I have all the technical difficulties. Well, do you want to take your 10-minute break now? We'll come back and then continue on. All right, that would be good. Let's come back 8:50. All right, so just to finish off that last slide for Parkinson's, as far as monitoring goes, one of the big things is education, obviously with any disease state, but this one especially because you're going to probably need a lot of help from other caregivers, family members, things like that. So make sure they're watching to know, how to manage these complicated drug regimens, especially as they get more progressive and they do get more complicated. Make sure you're looking at, not just the effects of the disease as it progresses, but also the drug side effects, because that may lead you to need to, either change your dose or change the drug altogether, things like that. And again, just look for also non-adherence. A lot of times non-adherence may be just coming about due to side effects from the medications. You can affect that, but they need to be honest with you and let them know, because again, there's no drug levels we're doing here. We're really just basing off how the patient's responding and what they're telling us essentially. Okay, so any questions on Parkinson's? Okay, so let's go on and talk about multiple sclerosis now. So what is multiple sclerosis? Besides hard to say. Demyelination of the neurons. Absolutely, that's perfect. And when you think about it like a lot of other kind of autoimmune kind of conditions, something like rheumatoid arthritis or Crohn's disease or things like that, where basically the body is not really recognizing, foreign versus itself, and thus it's, kind of attacking this particular target, which cases is the myelin sheath, demyelinating the neuron. Why is that important? Why does that matter? Like, why do we need myelin? Okay, what does it do to the signal conduction? Speeds it up, right? Absolutely. Because again, instead of having to go from sodium channel to signal and action potential, you can go from that notoranvir to notoranvir, and so that helps to speed things up quite significantly. So if you lose that myelin, signal transduction slows down. A lot of side effects that come about from that, right? So if you're looking at kind of the pathway, you can see here is pretty complicated, but similar to some of the other autoimmune conditions we've already talked about, we're going to see that we're using similar modalities. We're using similar things that are going to be affecting either specific inflammatory targets. We're going to be looking at glucocorticoids again are going to be really important here, right? Have you guys talked about this already? Okay, so this will be kind of new, but again, you're going to see that it's managed very similarly. The drugs may change up a little bit, but the principles are the same. You're dealing with either acute exacerbations, or you're trying to look at maintenance and trying to help prevent relapses from occurring here. And so again, we're going to see anti-inflammatories are going to be really, really big for the initial inflammatory response. We're going to see other drugs that are going to be disease modifying that help to hopefully prevent remissions from occurring here. But basically, when you have this inflammation, again, I'm not going to go through every single mediator here, but just know what you're going to see is this irreversible damage, because once you lose that myelin, it's not really ever going to come back for the most part. So again, three kind of categories for treatment of MS is you're going to be dealing with exacerbations. So again, this helps to shorten the duration and hopefully lessen some of the severity, because they can be pretty severe, requiring inpatient admission in some cases. And then we'll look at disease-modifying therapy. This can help to slow down the progression of disease. Again, it's not going to reverse it necessarily, but will help to slow it down, hopefully. And then we'll look at some of the symptomatic therapies to manage some of the complications of MS as they pop up. Now, obviously, our goal is to help hopefully improve quality of life for those patients and hopefully minimize any kind of long-term disability. A lot of issues that come about from MS. There's lots of not only psychological issues that happen. Patients have a lot of pain syndromes. They can get depressed from this. There's a lot of other kind of autonomic issues that pop up. They can be incontinent, and they have all kinds of other issues that come about from this disease state. However, if you're dealing with an acute exacerbation, IV corticosteroids are going to be the mainstay of therapy here. So a really good one would be IV methylprednisolone. Again, this would be one where they would come in to the hospital, get admitted, and receive corticosteroids for a few days to try to knock down that kind of major inflammatory response until they can get kind of situated on some other sort of therapy. Obviously, this is not something you want them to be on every single day, because we know there's lots of side effects associated with glucocorticoids. You guys remember any of the side effects? Yeah, so you can have weight gain that occurs from that. What was the first thing you said? Yeah, immunosuppression, absolutely. So you can see secondary infections. You're going to see that with a lot of these disease-modifying drugs as well. Anything else? Worsened glycemic control. You can see changes in mental status. You can have changes in mood, sleep disturbances. Lots of side effects associated with the corticosteroids. So again, this is really only going to be for those acute exacerbations. Typically within 3 to 5 days or so, you should start to see some improvement there. And again, earlier on in the flare-up, you can start treatment, the better it's going to be for the patient to help kind of limit the severity and the duration of that. So again, and actually in some cases, you may even have patients who will get administered what we call plasma exchange, basically try to pull off all those inflammatory cytokines via external means, and then resupply the patient with new plasma. Again, I'm not going to get super in depth on that, but just know that it could be used for some refractory patients who maybe are not responding super well to the corticosteroids. So disease-modifying therapy, that we're going to go over a bunch of new meds on this side of things. But again, you're going to find that the therapy is usually based on kind of where the patient's at as far as like severity of disease goes, and looking at a lot of the safety and tolerability. Nowadays, we're starting to get more and more safer medications to use. I'll talk about some of the older ones that may still be used occasionally and how pretty toxic they are. You'd find that with first-generation therapies, maybe see a decrease, relapse rate of about 30%, and also see a decrease in those white matter lesions. So again, that's good because it's slowing down the progression of disease and hopefully preventing overall severity for a longer period of time there. Now, again, these are not going to be things that work immediately like the steroids would. Corticosteroids, they should be working within a few days. These do take time for them to really be noticeable as far as their effects go, especially when you're looking over the long run of disease severity over several years. That's when you're really going to see the most benefit from these drugs. Now we're starting to have some more second generation agents, but these all tend to be very, very expensive. So some of these can range anywhere between $70,000 to $200,000 a year for treatment. But it is a lot better than the alternative of dealing with a lot of the complications of MS. Especially a lot of these patients have a lot of big pain issues, and then when you have a lot of pain issues, you end up taking a lot of opioids, and then you get addicted to opioids, and then it can be a whole big issue, right? In the middle of an opioid crisis, if we can help these patients with these issues, it's going to be better for them. So we used to use we call interferons. I think I've probably mentioned interferons once or twice before. You guys remember talking about this? They'll come up again. We talked about hepatitis a little bit later on, but again, these are going to be immunomodulatory. They are thought, and the helicopter's coming back. I can hear him. I'm just waiting for him to like kind of land and like just be right in front of the window. Anyway, so this is going to be helping with things like, suppressor cell function, activated lymphocytes. Also helps with some of that T cell proliferation, if they help to kind of limit that, and also that blood-brain barrier permeability. The more permeable the blood-brain barrier is going to be, the more easy it is for a lot of immune cells to cross that. If we can try to prevent that as much as we can, that's going to be better for those kind of inflammatory reactions against the myelin sheath itself. So there's several different interferons that are available. None of them are perfect. They cause a lot of side effects, and they are very expensive depending on the type you're going to be dealing with. Just know that these need to either be IM or sub-Q, because again, these are proteins that you're going to be administering. Oral's not really going to work so well for those. Okay, so these are going to be self-injectable medications they'd be getting administered. If you guys can't hear me, just let me know and I'll pause it until it passes. So a lot of adverse effects associated with the interferon. So we can see some hepatotoxicity. So you do want to look at their LFTs at baseline and do follow-ups. You can see CBCs, some depressed cell counts, a little bit of myelosuppression that happens there. The big thing you're going to find is a lot of flu-like symptoms, because again, this can modulate the immune system, kind of cause an inappropriate response to see these flu-like symptoms, myalgias, fevers, things like that. Pretty mild, but it can be problematic. And then some injection site reactions. But the big thing is depression. A lot of mood changes. Some people get very moody and very aggressive and angry when they're on these medications. Again, just depends on how the patient's going to respond to it. But because of that, as mood changes, a lot of patients did not like these medications. So they're not great, but they can still be used occasionally. Now we have this Glatiramer or Copaxone. This is actually another protein-based product, and a lot of these drugs you're going to find that we have an idea of maybe how they work, but we're not really fully sure. But this one is thought to kind of mimic some of the antigenic properties of this myelin basic protein. So we see MBP, that's what I'm kind of referring to as this myelin basic protein, and this is thought to be a T cell activator. So actually, by inhibiting the ability for that MBP to come in and activate T cells, you can prevent activation and hopefully limit some of that actual inflammatory response you would end up seeing with that. Again, another injectable product. You do see a lot of injection site reactions there, and some people will get some flushing, dyspnea, chest tightness. So again, it's something you want to monitor, at least for the first dose, see how they're going to respond to it. But it can happen with any dose. Even though they don't get it the first time, that may happen later on. We also have Natalizumab, and just based on the name, what do you think about that? What is that? Monoclonal antibody, yeah. So again, these are newer medications, again, very expensive, typically going to be injectable products. This one is actually going to be an antibody targeted against the very late antigen 1. Again, I don't know where they come up with these names for them, but maybe they found it last out of a group of them. I have no idea. But it's VLA1. Does anyone actually know there's actually a set of enzymes that are named after Sonic the Hedgehog? You can actually look that up. That is a true thing. And again, one day I hope to be a scientist that can name something ridiculous in the body. But anyway, so this one, again, is targeted against this very late antigen 1, and by blocking the interaction, it actually helps to interrupt this interaction with this VCAM1, this vascular cell adhesion molecule. Basically what this is doing is preventing that blood-brain barrier penetration of lymphocytes, right? So that's the main thing it's doing here, is preventing those lymphocytes from crossing the blood-brain barrier, getting to the myelin to cause that inflammatory reaction there. So just note, you guys remember when we talked about REMS programs, what those are? Those are those risk evaluation management strategies. These are for drugs. Think back to Accutane. We talked about that for acne. That is one that has a REMS program associated with it due to some risk for either teratogenicity or a certain side effect. This one has a REMS program too due to this progressive multifocal leukoencephalopathy that can occur. So that is a risk. This is something you would monitor for, but they need to be registered with that program in order to even receive the drug. Some other symptoms you may see, depression you wouldn't necessarily think about with based on the mechanism, but that is something we see with these drugs. And again, look out for respiratory infections. Anytime you're dealing with the inflammatory system and inhibiting it, you do run the risk for having some immunosuppression. This one's going to be pretty minor though, so just watch out for that. We have Fingolimod, or Gilenya. This is actually the first oral disease-modifying therapy for MS. This is actually one of the bigger breakthrough kind of medications, because now we have something oral that we can take instead of having to deal with these injectable products, which is kind of nice. This one is actually targeted against this sphingosine 1-phosphate receptor. So it's actually agonizing this receptor and activating it. And what's interesting, this actually is going to sequester lymphocytes into lymphoid organs, and it helps to prevent them from getting into the CNS. So if you can keep them all in the lymph nodes, you prevent them from going actually into the CNS and getting to those neurons. It's kind of a unique, kind of novel mechanism there. And as you might imagine, you see lymphoma associated with that, but again, it's a reversible one. As soon as you stop taking the medication, the lymphocytes can then not need to be sequestered there anymore, and they'll kind of go wherever they need to. But because you are sequestering those white blood cells, problem is you're going to see infections as a risk here. So again, immunosuppression while they're on the medication is a problem here. Also some bradycardia you can see with that, so that is a concern as well. Big thing to note with this medication is that you do not want to give a live vaccine at the same time the patient's taking this drug. Why do you think that is? Yes, there's some risk you may actually have disease activation that can occur there. You may not also be able to really get a good immune response developed to that. So again, the vaccine may not be as effective. Also, the vaccine may itself be harmful to the patient. So it's one of those things where you'd either give the live vaccine prior to starting a patient on Fingolimod, or you would do it 2 months after discontinuation. Once you give the system time to recover, those lymphocytes can leave the lymph nodes and kind of circulate again. That's when it's going to be more effective. Another one we have is called Teriflunomide. This is actually related to a drug we'll talk about when we get to rheumatoid arthritis called Levodopa. This is actually the active metabolite. This is another orally administered medication which is beneficial and works again as kind of inhibiting that proliferation of T and B cells. So again, reducing the number of cells available to go to the CNS. So one thing to note, big drug interaction here is actually going to be in patients who are taking warfarin. You actually see a bump in their INR about 25%. That is something to be aware of. You know, patients riding good. You remember what a goal INR is for someone who's on warfarin? Yeah, usually like 2 to 3 usually for most patients, like for AFib or something like that. Imagine 25% bump. They're sitting right at like say 2.8. That can get them to be super therapeutic pretty easily. So watch out for that. Another big one here as far as black box warning for hepatotoxicity and teratogenicity. So this is kind of interesting. So this is one of those these drugs that actually sticks around in the blood for a very, very long time. You can actually even detect it 2 years after you stop taking the medication. That's important because if you have a younger female patient, and typically what type of patients get affected with MS? Usually more females than males, you're going to find that men or women who want to get pregnant have a risk of having teratogenicity from this. So this is one of those things where patient education is super important. Like, what's their time frame? Or do you foresee yourself getting pregnant within the next 2 years? Doesn't take into account happy accidents and things like that, but you can at least have those conversations and make sure they're using appropriate protection. And actually, one thing that if you had someone who wanted to get pregnant or get someone pregnant, they could actually help to increase the elimination of the drug with what we call a cholestyramine washout. You guys remember we saw cholestyramine before? It's a bile acid sequestration, yeah. So we saw this back in the hyperlipidemia talk. So this is a bile acid sequestration, and actually what this can do is there's probably some enterohepatic recirculation of teriflunomide. If you combine that up with cholestyramine, it can help to increase the elimination of it. So it's kind of an interesting thing you can do to change the kinetics of the drug. So that may be one thing you need to try for that one. This is one, though, because it is a pretty potent immunosuppressive drug, you need to test for TB prior to, because if they have a latent infection, this can activate once you inhibit that immune system. So watch out for that. Another one, dimethyl fumarate. This one, we really don't know the mechanism, but it's another orally available drug, which is beneficial for your patients. Again, lymphocytopenia can occur here, increased LFTs, flushing, so nothing too notable with that one. And then one final monoclonal antibody, Alemtuzumab or Lemtrada. This is actually a monoclonal antibody against CD52. Again, by activating this or by binding to it, you can cause cytolysis and kind of increase cell death for those cells that actually express CD52, which are primarily macrophages, T and B cells. You're going to find that a lot of patients develop infusion reactions to this. You guys know how we can treat infusion reactions if we needed to? Slow down infusion. What else could we do, medication-wise? Yeah, Benadryl is a big one. We'll do that. It's an antihistamine. Sometimes we'll actually give steroids too along with it as well. So we'll give a corticosteroid, methylprednisolone, or hydrocortisone, something like that. So that can be very useful there. Usually Benadryls are kind of go-to. And if they do have an actual full anaphylactic reaction, then what could we use? Yeah, epinephrine is a go-to for in that case. Good. But again, increased risk of infections because we're inhibiting the immune system, so respiratory urinary tract infections, herpes. They actually do recommend patients have prophylactic acyclovir. If you guys remember back to our talking about antivirals previously, and again, test for TB beforehand because that is a risk there. And another kind of unique fact with Alemtuzumab is about 30 to 40% develop some sort of autoimmune disease. So even though you're treating an autoimmune disease, you have the risk of them actually developing further autoimmune problems. So you can end up seeing thyroid issues, type 1 diabetes, even for someone who maybe had no diabetes beforehand, hemolytic anemia, glomerulonephritis. So again, these are things you'll all be monitoring for. And again, probably not a big go-to drug. It might be something you'd use if they failed kind of other therapies. So as far as the disease-modifying therapies go, if you have a patient with kind of poor prognostic factors, you're really worried about them having progressive disease, you can really use any of these meds like the Natalizumab, the Fingolimod. This is probably getting much more use nowadays since it's an orally pretty active drug. Teriflunomide, any of these are fine as induction therapy. And these, again, take time to work, but once they kind of kick in, they will help to control those symptoms, hopefully end up preventing progression of disease. But again, patients are going to respond very differently to it, so Fingolimod might be great for one patient, might be terrible for another. You really just need to take all these patient factors into account. And then obviously the preference for a route of administration, oral is always going to be easier and better for most patients. As far as other management, so the other symptoms that come about, so they have a lot of spasticity associated with MS, things we can do to help manage that. So muscle relaxants can be very useful here. So we'll talk more about this when we talk about ortho stuff, but things like baclofen, things like cyclobenzaprine, these are all muscle relaxants. They actually work through the GABA-B receptor. If you guys remember back when we talked about GABA-A for seizure stuff, this actually works through GABA-B. But gabapentin or pregabalin, which we talked about previously, can be very useful here as well. And then botulinum toxin can be used. So again, if you have very significant spasticity, you can use Botox to help kind of paralyze those muscles to some degree. And then for the bladder issues, kind of go back and you look at the urology stuff we already talked about, but use things like anticholinergics like oxybutynin and sulfenacin. Those can all be very useful. Or in some cases, they may need self-catheterization. Obviously, if you want to hold off from that if you can, that's going to be beneficial for them. For some of their sensory symptoms, so some of their kind of neuropathic pain, they can develop from this carbamazepine, phenytoin, and then we'll talk about tricyclic antidepressants later on in the behavioral section, but those are another group of drugs that you can use for neuropathic pain issues. And then as far as fatigue goes, we'll talk about antidepressants later, but in some patients they may need things like Amantadine, which we just talked about for treatment of Parkinson's. Sometimes that can be useful for helping kind of wake the patient up and get them a little less fatigued, or things like, we'll talk about this probably in the behavioral section. I had to think about it, but these, anyone ever heard of modafinil or armodafinil, Provigil and Nuvigil are the brand names? A lot of people use it for shift work disorder. So if you work a lot of night shifts, a lot of people have hard times with their circadian rhythms and sleeping appropriately. These drugs can be very useful to help to kind of reset them a little bit, so that way they can be more awake in the nighttime and sleep better during the daytime. So again, my sister, she's a CRNA now. Oh, not CRNA, she's a nurse practitioner, and she has always worked night shifts for whatever reason. Ever since she was a nurse working in the ER at nighttime, she's always done that and always wrecked her sleep, but this drug actually ended up working pretty well for her. So some people may benefit from that. And then amphetamines, a lot of your ADHD meds, which we'll talk about later, can be useful there. Okay, so any questions on MS? So again, that doesn't really have a really good flow chart. Really, they're having acute exacerbation. Corticosteroids are a way to go. And then once they get stabilized, using those disease-modifying therapies, and really just finding what works best for those patients. Usually something like Fingolimod is going to be a good one to go with. When Teriflunomide, if they're not looking to get pregnant, those are things to kind of consider when you're looking at treatment for MS.
I just want to clarify, those are everyday medications.
Those would be, yeah.
Not things
Well, depend. Some things like the monoclonal antibodies would not need to be given every day. Some of them may be weekly, some may be monthly. And get big into the dosing, but those typically have less frequent dosing. But the oral ones would be like an everyday sort of thing. Cool. Okay. Well, let's talk about headaches real quick, since I probably give you guys one every Friday morning now instead of Wednesday nights. There's probably a little bit of an improvement there, but major headache categorizations we're going to talk about here is migraines, which has kind of the most wide pharmacotherapeutic options available for us. We'll talk a lot about migraine. We'll talk about tension and cluster headaches a little bit. Have you guys covered anything about headaches, migraines? Perfect. So you guys know how to treat those already, right? That sounded not as confident as I would hope. No, it's okay. So what's a migraine? What's going on with a migraine? What's the pathophysiology of a migraine? What happens? Well, is it vasoconstriction or dilation?
Either.
Actually, dilation that's occurring here. So actually a lot vasodilation that occurs. Basically, what you're seeing with a migraine is you're having, and again, some people have auras, some people have these kind of prodromal symptoms that occur before a migraine. I'm not going to get super in depth onto that. Those can be useful when you're trying to decide when to actually start to give some of these abortive medications. But basically, what you're seeing here is you have some sort of spread that's leading to activation of these trigeminal nerves and leading to vasodilation of some of these cerebral vessels. Basically, when you have these vessels start to open up, that will cause pressure on these trigeminal nerves. That causes a lot of the pain associated with the migraines, and so that's going to be one of the big places we're going to look to our pharmacologic options here. So we're actually going to be looking at a lot of vasoconstrictors, because if we can close down those cerebral blood vessels, that's going to help to relieve that pressure off the trigeminal nerve and hopefully decrease a lot of the pain associated with the migraine. Okay, so it's going to be one of the big options we're looking for. That's kind of as far as we want to get for pathophys for our sakes, because that's how most of our drugs are going to be working. So obviously there's non-pharmacologic therapies available. There's a lot of OTC medications that we can use for treatment of migraines and prescription therapies. I don't know if any of you guys experience migraines or know someone who does, but how often do like the OTC stuff really work for a really gnarly migraine? Not often, right? So this is, again, one of those big things where, we like to have good medications available to the patients. They can treat themselves. A lot of times patients still end up in the ER or, the acute care centers, things like that, for treatment of migraines, because they can be pretty severe. They can be very debilitating for a lot of patients, depending on how severe they become. I remember I had one friend in college who basically, whenever she had a migraine come on, she just went to her dorm room, closed the door, turned off all the lights, no sound, and was there for like 48 hours. And just had no good option for her. That was the only thing that really kind of got her through that help, because everything, had the phonophobia, everything just kind of set her off. And so it was very debilitating for her. It was, good 2 days she couldn't really enjoy the weekend or whatever happened to be. Anywho, so things like stress management can be very useful here, relaxation training, biofeedback, any of those things can help if there's a behavioral component to it. And then obviously avoidance of triggers is really a big one. So if you know certain things will set you off and cause a migraine for your patient, then try to avoid those, obviously. But good sleep and rest and regular exercise can all be very useful. Sometimes ice can help, but again, it's not going to be as good as some of these medications we'll talk about here in just a little bit. Common triggers, you can see things like alcohol, or sometimes alcohol withdrawal can sometimes precipitates migraines. Caffeine withdrawal for sure. I don't know if anyone ever tried to go cold turkey off of caffeine. Not fun. Not fun from a headache standpoint. Even like pickled foods, I don't remember that components in there that can cause that, but MSG, which you find a lot of like certain Asian foods, aspartame, tyramine, everyone can act a little bit different and responds a little different to these triggers, but these are just kind of some options you may consider. Environmental triggers, high altitude can sometimes trigger off some people, loud noises, strong smells, all of that can be potential triggers. So when looking at therapy, it's important to remember that we have some that are going to be acute treatment of migraines, or meant to be to terminate the migraine. We call those abortive therapies, and there's some that are going to be preventative. Note that if you have a lot of the preventative medications, if used inappropriately, can actually cause migraines. So it's one of the things you have to be careful of when we talk about those a little bit later on. Basically, how we decide to use these should be based on how often they're having migraines, how severe the symptoms are, and kind of the duration of their headaches. And so we'll talk about that and how we choose which drugs we're going to choose. So generally, we want to administer medications at the onset of a headache. If they have an aura and that gives you an idea of they're going to be having a migraine soon, you can give the medication then. Hopefully that will help to prevent it from occurring in the first place, which can be very beneficial. But a lot of patients don't have auras. You may not know when it's going to come about. Just know that there's no medications to actually treat the auras that occur with these, so there's nothing we can really do about that, unfortunately. But hopefully if you can prevent the migraine, that's going to be good enough for your patient. And then typically we want to limit use to no more than 2 days a week of these abortive therapies. Okay, what do you think that is? You may get some tolerance to it, but you guys ever heard of medication overuse headaches? It's actually, you get this hyperalgesia that occurs where basically the patient is just much more sensitive to these migraines and things like that, to where if they're using these medications too frequently, they end up having kind of worsened headache disorder, right? And so it's one of those things where you want to try to use it as little as possible. But if they need it, and you want to go ahead and give it to them. But we'll see how we can use some preventative therapy to limit how often we need to use these kind of acute treatments. So for mild to moderate migraines, if you can get away with using something like an NSAID, simple analgesic, usually acetaminophen by itself is not going to be good enough, but using acetaminophen plus aspirin or plus another sort of NSAID like ibuprofen, naproxen, all of that can be very useful. Just combination products like caffeine, aspirin, acetaminophen, like those can be good products for some patients. Why do you think we use caffeine? Yeah, it actually can help with vasoconstriction. So just you think about too much caffeine can raise your blood pressure. By vasoconstriction, same thing can happen in the cerebral vessels. That's how caffeine can be very useful. And imagine if you have a caffeine withdrawal, what do you think it does to all those cerebral blood vessels? They're going to open wide up, and that's why you get those migraines associated with it. So it kind of makes sense based on the physiology and the pharmacodynamics there. Anyone ever heard of ketorolac or Toradol? Toradol's a brand. That's a good, I believe there is an oral formulation, but we don't use it very often. But usually it's a really good IV, IM sort of medication you can give if they're coming into the acute care setting or an emergency medicine setting. Toradol is a really good one to go ahead and give. Has very good like opioid sparing properties for a lot of other pain conditions. So a lot of patients come with a migraine, they're going to get a liter of fluids and they're going to get some Toradol. That's going to be a very good way to start off treatment. Hopefully help to mitigate some of the pain they're getting with their migraine. Now, another thing you can see with a lot of patients who get migraines, they get very significant nausea and vomiting associated with that. So you need to treat that as well, because again, if they're vomiting, are they going to be able to take any oral medications? Not really, but also nausea and vomiting is no fun for anyone. So we have a lot of medications that can help to treat that. We'll talk about the phenothiazines when we get to the behavioral section later on. But one of the things we kind of mentioned in the GI section we already talked about is that a lot of these drugs that block dopamine also have very significant anticholinergic properties as well. All of that can be very useful to help to mitigate those effects of that nausea and vomiting they're experiencing there. So promethazine is a good option here. Or Phenergan is nice because it has like a suppository it's available if they're throwing up. Metoclopramide or Reglan is a good option here as well. And then you can also use your serotonin antagonists like ondansetron, Zofran can be a good option here as well. So any of these could work. It's also nice as well. Phenothiazine is also going to have a much more of a sedating effect. So if it's something where the patient needs to get back to their normal daily activities, phenothiazine may not be a good option for them. But if they're going to be going to sleep soon, it might be a great option to help them sleep through the migraine to some degree. Obviously, ondansetron is going to be a little bit better non-sedating. So they need to stay up or need to drive a car, that can be a better option for them. So talking about the actual abortive treatment, the actual things that are going to help to really kind of knock this migraine down, we're going to have our ergots, which are going to be vasoconstrictors, which we already talked about in the Parkinson section. We're going to have two that fall into the category. We have ergotamine tartrate, or Ergramar, which either comes as an oral medication or it's a suppository. And then we have dihydroergotamine. Another name for this is DHE. Based on the name there. Migranol's name, you either have a nasal spray or parenteral administrations available. So you can either use the IV as a nasal spray, because again, if they're vomiting, you want to have other options to administer. So that's why you see so many nasal sprays and injectables and suppositories available for these drugs. Anyway, the way that these are working for migraines is they're working to activate serotonin receptors 1D and 1B. These are important to remember. So again, if I were to ask, like, it's important not to get these mixed up, right? So you just don't want to say, like a 5-HT3 antagonist, it's going to have very different effects than a 1D, 1B agonist. So it's important to keep those distinctions in mind between, like, your Zofran versus something like, DHE. But these are 1D, 1B agonists. They'll activate those receptors and it will cause vasoconstriction. Okay. So they can also help with some of the release of a lot of pain-causing peptides. So think about substance P, other pain-causing peptides. They can actually help to prevent some of that release there as well and decrease some of that inflammation. So a little bit different mechanism on the presynaptic side, but main thing is causing the cerebral vessels to squeeze down. Okay. So these are also nice because they have a long half-life. So the longer the half-life these drugs have, typically the less recurrence of migraine you're going to have. It's a big problem you run into where if you use kind of a short-acting medication, you may deal with the migraine now, but it may come back several hours later, and it's, again, no good for your patient. So that's one big benefit there. The other thing you want to be careful of is that these cause a lot of nausea and vomiting. So you need to usually pre-treat these patients with something like a Zofran or a Phenergan prior to getting it, because otherwise they're probably going to throw up from that, if not from the migraine. And the other big thing is we mentioned these are vasoconstrictive, not just in the brain, but also elsewhere. We mentioned, with St. Anthony's fire, these patients are getting gangrenous limbs due to the vasoconstriction. So you can see that same thing for patients who are getting DHE or any of these ergots. And so you have to be careful. You don't want to use these in patients with uncontrolled hypertension. You don't want to use these in patients who have any kind of vascular coronary disease. You have to watch out for that, because again, if you could induce, say, a heart attack in a patient who's already had issues with angina or something like that due to the vasoconstrictions. Be very careful with those drugs. But for normal, like in the ER, at least in the morgue, you see a lot of young, relatively healthy female teenagers, they're coming in, like they have no contraindications for receiving it. The only caveat to that is you need to check a pregnancy. These are very, very teratogenic Category X, you do not want to use these on someone who's pregnant. So that is one thing we'll actually check for. So again, if you think about migraines, again, typically affects a little bit more females than males. Those are kind of your bread and butter type of migraine patients. You need to check a pregnancy beforehand if you're going to use these. So the other drugs we have are going to be the triptans, and these again are going to be more specifically 5-HT1D and 1B agonists, but they don't have they work a little differently than the ergots. They don't really have the same kind of severe vasoconstriction that it can occur kind of systemically, but these are also very good drugs that have kind of taken the mainstay of therapy. These are kind of the gold standard. So we have sumatriptan, which is kind of the first generation, the very first triptan that came out. Imitrex is a brand name for that one. I'm sure most of you guys have heard of Imitrex before. Again, lots of options that are available. They can do sub-Q, you can do intranasal. I don't know why I put NS there, it should be like IN. It has oral options as well. And then we have all these kind of congeners, these kind of Me Too drugs, which we consider to be the second generation triptans. Really the big things where they're going to be differing are going to be based on what dosage forms they have available and basically their half-life and onset of action. Typically with these drugs, the longer the half-life, the longer it takes for them to be effective. So it has a slower onset of action, but it helps to prevent recurrence. So if you have a patient who say has aura with their migraines, they can take one of these longer acting ones early, hopefully to stave off the migraine from occurring and then prevent relapse, recurrence from happening later on. Versus ones that have shorter half-life, they tend to work a lot more acutely, a lot more early on, so that can be better for someone who's having the acute migraine right then. So again, different considerations for different patients. And some people respond to ones better than others, and the insurance is a big issue as well as far as what they'll cover. So again, working on those 1D, 1B receptors, causing that vasoconstriction, also can deal with some of that inflammatory release, similar to the ergots. Now again, a lot of patients are going to be get a lot of efficacy out of this, but again, a lot of them will have recurrence. So this is where you can use things like the Frova or the Emerge. Those tend to have the longer half-lives, and they will prevent that recurrence a little bit better than something like sumatriptan. Okay. As far as side effects go, a lot of patients will get some side effects associated with this, and you can see some patients can have chest symptoms. So as you're administering this, they may get some tightness, some pressure, some pain associated with that. Just let them know that, hey, that's normal. It's associated with the drug, but it will pass with time. It's nothing to be all that too concerned about. However, you can see some increase in blood pressure for some patients. So if they have a history of MI, coronary artery disease, that would be more of a concern. So that may be indicative of, hey, if you're having really significant chest pain, maybe try nitroglycerin and see if that's what the issue is versus it just being a side effect of the drug itself. So kind of watch out for that. And then the other big thing to watch out for is you do not want to use these within 24 hours of the ergots. Why do you think that is? Yeah, they can work synergistically, cause way too much vasoconstriction. So history is really important, especially when they're coming into the ER. You need to ask, hey, have you tried anything for your migraine already? If they say, oh yeah, I already took my sumatriptan at home, it didn't work, I'm not going to give them an ergot in the ER, right? Because I'm worried about that interaction there. Now, in some cases, they can use, say, the first dose of sumatriptan didn't work. They can get potentially another dose several hours later. That's going to be okay. We'll really see that kind of synergism with the ergots. But again, do not want to mix these two within 24 hours of one another. I mentioned a lot of patients will do just fine with sumatriptan, so that's usually the gold standard. That's the cheapest one you can get a hold of. But for some patients, you will have that recurrence that happens, and they may require a different type of triptan. Most of them tend to be pretty equally efficacious, but the big thing you're going to find in the second generation ones is that they're designed to decrease that recurrence there, hopefully increase the bioavailability. You can see some oral administration for some of these, and hopefully decrease some of those side effects. And they do that by having better potency, better penetration of the CNS, and hopefully a better half-life. So basically, when you're having these patients for acute treatment, you want to make sure that they're trying NSAID first. They're responding pretty poorly to that. That's when you can move on and try using a triptan for them. Usually I try to go triptans most often, but some providers just like ergots, usually kind of more older school providers. So we still use a decent amount of DHE at the ER over at Nemours, but most patients get sent home on something like a triptan, right? So sumatriptan most commonly. Again, they have a lot of nausea and vomiting. Use a non-oral route. That's going to be best for those patients. And you need to give about an hour for the sub-Q to work. It's usually the faster version. If they're going to use intranasal or PO, give it about 2 hours for it to really kick in. So it's kind of a bummer. They're going to have that headache for that period of time, but just know that it takes a little bit longer for the intranasal or the PO version to work. Definitely have them take the NSAIDs first, and while that, so that way something is working while give the time for the triptans to kick in. Again, I mentioned watch out for that vasospasm if you mix these two ergots and triptans within a 24-hour period. And again, try to avoid using these more than 2 days out of the week. Again, when you're getting that frequent of symptoms, this is where a preventative therapy can be very useful for your patients. So it goes into the medication overuse headache. Basically, if you're using these medications, say either ergots, triptans, opioids in some cases for some patients, or other analgesics, using more than 15 days out of the month. So every other day they're having to use these or more. Or if they're having to use like ergots or opioids, more than 10 days out of the month, that would be considered medication overuse. The problem is you end up seeing that they get kind of in a hyperalgesic state where they're kind of more sensitive to that pain the more they take these medications. The idea is to try to limit that and try to gently titrate them down as best you can. Usually what you're going to find is that 2 months after discontinuation, they actually have their symptoms improve. Again, it's not a very pleasant process, but it's something that usually needs to happen for a lot of these patients. And typically, if they're getting less than, say 7 to 12 analgesic tabs or capsules per day, you can go ahead and discontinue the medications pretty abruptly, or you may want to taper it over a period of time. Just depends on how they kind of respond to that. And then this is where you're going to start your prophylaxis medications, which I'll cover in just a few minutes here. Just know that there will be some withdrawal symptoms. Some it might be more severe than others. Just be aware of that. But certainly, if they're getting more than 12, tabs or caps a day, or if they're pregnant, you definitely do not want to withdraw abruptly. You want to titrate down over that 4 to 6 week period. Okay, so who should be a candidate for getting preventative therapy? Usually those that have kind of recurring or frequent migraines despite usual acute treatment, especially if they're having overuse of those medications. This would be another good indication to use preventative therapy. Also, they're having a lot of adverse drug reactions. You want to prevent using that acute therapy. This can be very useful to help prevent that as well. So first line is going to be a beta blocker. You think, well, why would a beta blocker work? If you block beta receptors, what does that normally do to blood pressure? You should decrease. You think, well, maybe I'll have vasodilation, and that's true. And acutely, if you were to give a big dose of a beta blocker to someone with migraine, you can actually induce one, right, due to some vasodilation that occurs there. However, with a lot of these, you're going to start very low dose and then gently titrate up in order to avoid that from occurring, right, until you achieve kind of their maximal efficacy. Now, for a lot of patients, and this is first line for many of them, about 80% should achieve some efficacy here. Propranolol is kind of the original one that we use most frequently, and it makes sense if you think about propranolol being very lipophilic, gets up into the brain very easily. However, others have been used as well, so really any of these are good options. Again, propranolol, is that beta-1 selective or not? It is, propranolol is not. It's going to be non-selective. So remember, A through M is going to be your selective beta blocker. So something like atenolol, metoprolol, those are all going to be good options if the patient has asthma, right? You don't want to worry about that reactive airway disease. Mainly is that the main thing you're doing by giving a beta blocker chronically, you're hoping to prevent some acute vasodilation that can occur when the patient would have had a migraine. Basically, kind of resetting their kind of resting point and hopefully preventing that vasodilation. That's the main thing. Also, there's some thought that inhibits serotonin release from platelets, but it's kind of an ancillary kind of effect there. Other drugs you can use include your anticonvulsants. So if they could not receive a beta blocker due to comorbid conditions or allergy or whatever, you can also use some anticonvulsants. So this is where something like divalproex or valproic acid can be very useful here, right? So I mentioned a lot of our anti-seizure medications have a lot of other ancillary uses. This is one of the big ones. So divalproex or valproic acid can be very useful here. Some of this is thought to help prevent that kind of spreading wave that leads to the vasodilation that occurs. So if you can prevent that from occurring, hopefully you prevent the migraine. And then Topamax is going to be the other big one, topiramate. Again, multiple mechanisms there, hopefully depressing the activation of that trigeminal nerve. That's what leads to a lot of the pain that actually occurs for those patients. Starting to see more and more Topamax becoming kind of first-line agents. Also kind of helps with weight loss as well, so that can be an additional kind of benefit there. But just be aware of that kidney stone problem. Being in Florida, we have a lot of calcium in our water. You see a lot of kidney stones, so that's one of the things to consider. Some patients have also tried something like tricyclic antidepressant. We'll talk more about these when we get to the behavioral section, but just know that they also can be useful. And then sometimes we'll try an SSRI, which again we'll talk about in the behavioral section. But mainly for our purposes, think a beta blocker, think one of those anticonvulsants like valproic acid or Topamax. Those are going to be your main ones to look at there. And some patients may actually respond well to calcium channel blockers, like verapamil can be a good option here. Again, this is one of the things we want to start at very low dose and gradually titrate up, because again, too much too early can lead to vasodilation, it can actually induce a migraine for them. So watch out for that. And then botulinum toxin can be useful, especially if they have kind of very tense neck muscles that lead to their migraines. That can be very useful to have those injections there to loosen those muscles up and hopefully prevent the migraines from happening. So for some patients, select patients, they might get some benefit from that. Again, like I mentioned, start low and go slow with most things. And then you'd consider it successful if you have the frequency or duration decreased by about 50%. That's kind of what your guide is. Again, you're not expecting to get rid of migraines completely, but hopefully a 50% reduction would be pretty good. And then you consider, continue for about 2 or 3 months, see how it's going to work, and then, really get full benefit after 6 months or so of therapy. Obviously, avoiding kind of interfering medications there, and then also consider your coexisting issues, right? So if they have migraines and they have a seizure disorder, maybe valproic acid is a really good option for them. If they have hypertension, maybe verapamil or beta blocker is going to be good for them. So kind of keep those things in mind about which drug might be best for your patient. Okay, so I mentioned migraines tend to have a higher prevalence in women. Some clinical consideration, there is going to be a hormonal component to this. So you have to think about things like menstruation or contraceptive use, and we'll talk about pregnancy and menopause here as well. So we'll talk about those a little bit more in detail. But basically, you'll find that around 14% of female migraine patients tend to have this occur right around the menstruation there. The nice thing about this is they're very predictable. You can predict when the attack is going to occur. We know this is due to estrogen decreases that occur during the cycle there. And so the idea is if you can predict when it's going to happen throughout the month, you can actually give these abortive medications such as triptans, or can use things like NSAIDs or potentially estrogen 2 to 3 days prior to the onset, and then continue for about 5 or 7 days. And hopefully that'll prevent any of them from occurring during that week period or so. Now, as far as oral contraceptives go, just keep in mind that for some women, you may see worsened migraines associated with that. You may see improved migraines. You may see no change whatsoever. Most people probably have no change. But if you did have someone who is having migraines associated with oral contraceptive use, sometimes you can do things like changing the formulation, right, or decreasing the dose of estrogen that they're getting. Sometimes that will help to balance things out a little bit. Some cases, if the estrogen component is what's causing the migraines, you can actually do a progestin-only pill. We'll talk more about this in the OB-GYN section later on. We talk about different types of contraception, but usually most products have estrogen and progestins in them. But if you can switch over to progestin-only, that may be better for some of them. And then some people will either discontinue use altogether, or you can actually use kind of a continuous treatment or actually decrease the number of estrogen withdrawals. So normally, normal dose or normal pack of oral contraception, you would take it for 21 days, and then you have basically 7 days worth of placebo pills, right? And then you restart the whole cycle again. There are certain products that are meant to be given continuously, where you may only have, say, 4 withdrawals of estrogen throughout the year. Something like that may be beneficial for some patients, but we'll talk more about that later in the OB-GYN section.
Does this relate to like implants or anything, or just the oral?
These are really just referring back to the oral medications, usually like the vaginally administered ones, like intrauterine devices. Those really don't see much systemic effects. That's not really a big deal. And if you'd had something like a depot shot of like medroxyprogesterone, you really wouldn't see any problems with that either, because that's just a progestin. Good question though. B6 has also been seen to help some as well. Again, I can't really test the efficacy of that. Okay, if you had migraines in pregnancy, typically drug of choice for most pregnant patients is going to be acetaminophen for most pain concerns. You don't want to use ergotamines; those are actually category X. NSAIDs can be problematic, especially in the 3rd trimester, those are category D, and then the triptans are category C, which we mentioned. Category C means what? Hard to say, right? We don't really have a good evidence to say one way or the other. In some really severe cases, you may try opioids, but that's always kind of a last line of effort you use for some of these patients. Again, opioids are typically don't have a good mainstay of therapy in treatment of migraine, so you typically try to avoid those if you can. Try some acetaminophen. Most pregnant women are concerned about drug exposure to the fetus anyway, so a lot of them will just try to tough it out. But for some, you may need to use some of these more these different alternative methods. And then talking about tension headaches briefly. Again, you kind of make this a little bit more broad and kind of talk about most other types of normal kind of run-of-the-mill types of headaches here. Again, OTC agents are going to be the first line go-to for most of these. NSAIDs like ibuprofen, naproxen, all those are going to be really good options for most patients. Acetaminophen may be useful for some. What's the concern with using too much acetaminophen? Yeah, you worry about liver damage. So if it's something where they're taking more than excess of 4 grams a day, like they need to come and get evaluated. Maybe you need some preventative therapy there, because that will lead to some liver damage long term. Excedrin, usually a combination of like aspirin, caffeine, and acetaminophen. Those can be very useful as well. Just get kind of multiple modalities working there. Has anyone ever heard of Fumarate or Furanol? I see this prescribed way too much. This is probably one of the #1 drugs associated with medication use, overuse headaches, because they will just get prescriptions for it for a ton of it, and they'll just take it forever, every day practically, and it's really not that appropriate. But basically what this is aspirin or acetaminophen. So if you are set, so think about acetaminophen, CET, that's how you know it's Fumarate, or aspirin will be Furanol, mixed with caffeine and butalbital. Anyone ever know what butalbital is? It's a barbiturate, yeah, so I've already mentioned that before. So it's a barbiturate that is meant to, you can imagine having similar effects as like, valproic acid. Maybe helps to depress that spreading wave of pain. Who knows? But they try. Usually, it's more for this kind of sedative effects than anything else. But this is something that they will use. Actually, if you look at the studies, it's equal to placebo in efficacy. So not all that very useful. And a lot of times you'll find patients who have rebound headaches coming off of this. And so I can't tell you, seeing a lot of overdose patients in ERs for either accidental or otherwise exposures. I saw a lot of patients taking Fumarate, Furanol, because again it's a non-opioid. You can give to patients who are coming in complaining of pain. So I saw a lot of overuse of it, probably inappropriately. So be selective in who you give this to. If you have a history and they know they really respond well to it, then it's probably okay to use. But it's not really a great drug otherwise. And as far as prevention goes, we can try things like tricyclic antidepressants. Amitriptyline is probably the one we go with most often. SSRIs are going to be not nearly as effective. But one of the other big things you can see, if a patient has headaches associated with smoking cessation can be a big help with that. So those are kind of the biggest things as far as preventive therapy goes for kind of other types of headaches. So that's it. That's the end of neurology. Any questions on that? Forget what we cover next. Anyone have it pulled up? Is it behavioral? Makes sense. Probably all you could use some mood stabilizers in this class, right? Just feel a little bit better. Yeah. Okay, so everyone's working on their homework assignment, right? It's going to be I re-uploaded the syllabus, so made the lines a little bit more, should be more obvious where the test is going to be occurring when assignments are due, as far as which week the class is going to be. So February 16th will be the day of the test, and also when the assignment is due. Any questions or anything I can help you guys out with? Yes, ma'am.
When you give a liquid medication, do you have to indicate the size bottle that the pharmacist needs to?
No, so you need to say, another question came up, someone said, can I use QS? And what's QS mean? Quantity sufficient, yeah, to fill a prescription. I would not want you guys to put that on these assignments. Basically, what you need to put is like dispense and the actual amount it would take to fill that medication order, right? So the patient is taking 10 mLs a day for 5 days, you would write dispense 50 mLs, right? So be specific like that. The pharmacist will figure out the rest of it, right? So for instance, if you have a medication you're only going to give, say, 50 mLs for the full course of treatment, but it only comes in an 80 ml bottle, the pharmacist is just going to give them an 80 ml bottle, right? But you want to make sure that what you're writing for, the actual instructions make sense based on what you're actually giving for the dispense quantity. Because that if there's a discrepancy there, that's going to be a call that the pharmacist is going to give you. He's like, hey, you wrote for 500 mLs of this, but the patient only needs 80. Like, what's up with that, right? So make sure that those make sense based on what you're actually prescribing.
So hoping that if a bottle was too small and you needed more for them, you would say like you need a refill as well?
No, the pharmacist will probably just give them 2 bottles. Yeah, they'll figure that out. Like if you need an actual refill, like the patient may need another course of it, they're supposed to take it every day for a month, you're only giving out a month's supply at a time, then yeah, that would need refills. But if it's something where the bottle size you're not really so concerned about, the concentration you are concerned about, you want to make sure that it's actual concentration that's available, and it makes sense based on what you're calculating as far as the dose and the volume goes, right? Because if you screw that up, then you can either under or overdose your patient, or for something that's not available, the pharmacist is going to call you. They're going to be like, hey, you wrote for a 50 milligram per ml concentration, that doesn't exist. What the heck do you actually want, right? Because that could be a mistake. It could be you either picked the wrong drug or you picked the wrong concentration when you wrote it down. Make sense? Those are always going to be the hardest ones. I'm always going to try to include at least one liquid medication on there because that's probably what you guys need the most practice with. Anyone can write, take 1 Q daily, dispense 30, 6 refills. That's easy, right? But actually figuring out like, okay, how much amoxicillin do I need to give this patient in mLs? Because again, the patient and the parents get home, it says give them 80 milligrams, and they're like, oh, how does 80 milligrams? A lot of people are not equipped to do that kind of calculation or used to it. So I want you guys to be able to do that. Anything else? All right, I'll see you guys next Friday. Happy Friday.